on. I would like to invite the next set of chairpersons. We have Dr. Anna Soyara, Senior Resident, Department of Medicine, Goa Medical College, and Dr. Vipul Chavra, Diabetologist and Cardiometabolic Physician, PG Diploma, Diabetes Europe.
Thank you so much. So we are having a wonderful session at the 12th World Congress of Diabetes India, and moving to the SGLT2 Symposium. We are on DPP 4 Symposium, and for that our first speaker is Dr. Vinayak Sinha sir from Kolkata. Sir is a MBBS, MRCP, FRCP, CCST, Endocrinology and Diabetes UK, Consultant Diabetes Endocrinologist, MD in Fortis Hospital, Kolkata. He is a past Consultant Diabetes and Endocrinology, University Hospital, Birmingham, membership of Royal College of Physicians of UK in 1995. We all know sir, and without wasting much time, the diocese is yours, sir.
Thank you very much for your very kind words of introduction, and good evening everybody. We are here to be talking about linagliptin and how we can simplify care of diabetes with linagliptin. So there are various subgroups of patients with diabetes who we see in our day-to-day practice. They vary from having various BMI and various levels of glycemia. They have come in various age groups, various ethnicities. There are various multiple comorbidities like kidney disease, heart failure, or heart disease. They have varying durations of diabetes, and there are other problems that these patients face. So how does linagliptin fare in these patients? There is no doubt that linagliptin produces a significant HbA1c reduction to the tune of about 1% in patients who are treated with linagliptin, and this is across the board in patients with diabetes, which I will show you in a minute. But in combination with what is first-line treatment, which is metformin, what you see is a very significant reduction of HbA1c to the tune of 1.3 to 1.7 if the HbA1c is about 9%. But if you take this HbA1c, higher you go, the greater is the fall. There is about a 4% reduction of HbA1c with a combination of these drugs. In addition, diabetes has evolved, and we know that diabetes continues to progress as the days go on. And initially you have treatment with monotherapy, and thereafter you have to graduate to dual therapy, and then you go to triple combination, and diabetes is relentless, and you go on to insulin. However, throughout the course of this progression, this relentless progression, what you see from linagliptin is a continuous endeavor to control the diabetes, and across the range you find there is a reduction of HbA1c to the tune of 0.6 to 0.9%, which you will all admit is extremely significant. In addition, it does not only work in these groups of patients, it also works in groups of patients of varying BMIs. So we tend to see patients who are very slim and to the very super obese, and in patients who have a BMI of 25 and between 25 and 30, between 30 and 35, and the super obese greater than 35, you see a significant reduction of HbA1c all across the board with usage of linagliptin. And in addition to that, we are an aging population. India is aging, and we are progressively getting more and more people who are elderly. You find that in all groups of patients, whether they are below 65 or more than 65, linagliptin continues to produce a very significant HbA1c drop, which is quite pronounced, particularly in the elderly group, because in this group we need a drug which will produce good control of glycemia without the added risk of hypoglycemia. People who have had diabetes for a long duration, people who have had diabetes for a short duration, people who have been recently diagnosed with diabetes, all of them have statistically significant reduction of HbA1c. In fact, if you look at patients who have diabetes for a long period of time, which is more than 10 years of diabetes, you find that there is a very statistically significant, almost 0.5% reduction of HbA1c, And if you look at the proportion of patients achieving the target HbA1c of, so whether you look at 7.5 to 8 or 8 to 9 or more than 9, you find that linagliptin is superior when compared to competitors in reducing HbA1c across this entire spectrum. In addition to this, we find patients with from different ethnic backgrounds, including Asians, Hispanic, Black, African American. The importance of usage of linagliptin remains because it continues to produce a very consistent reduction of HbA1c all across various ethnic backgrounds. There is a very strong group of patients that we see who have CKD. There are multiple patients that we tend to see in our clinics who have chronic kidney disease, and we see them from a normal, we see them progressing to CKD type 2, then to CKD 3, and then to end-stage renal disease. And in all these groups, HbA1c reduction remains prominent. In fact, in people who have late renal disease, the HbA1c reduction is even more prominent and is statistically highly significant. Add to this, we know from the Carmelina study that linagliptin leads to slowing of the progression of albuminuria, kind of amplifying its positive effects on the kidney. So while talking about Carmelina and Carolina, let us just analyze these two studies. As we know, Carmelina and Carolina looks at the whole spectrum of diabetes, while Carmelina looked at sicker people who had established cardiovascular disease or established CKD. Carolina looked at early diabetes, or garden variety diabetes, patients who initially come to us who are, yes, at an increased risk of CVD, but yet do not have established cardiovascular disease. And as you can see, Carmelina recruited patients who had an HbA1c of between 6.5 to 10%, the entire spectrum, while Carolina restricted to patients between 6.5 to 8%. And what did this show? That in Carmelina, there was no risk of increase in risk of linagliptin versus placebo on CV or kidney events, irrespective of GFR characteristics. So 3P MACE, they all remain the same. As you can see, the dot is right at the center of the midline, showing that there is no difference with placebo across a range of eGFRs. The second lot is heart failure. Again, there is no difference in the kind of results that you get. And also, in composite kidney outcomes, there is no difference in what you get when you treat patients with linagliptin. But add to that, what is really beneficial to see in patients with whom hypoglycemia is a huge risk, patients with CKD, patients who have the highest risk of hypoglycemia, hypoglycemia rates with linagliptin were comparable to placebo. So it was as good as not giving a drug as far as reducing the rate of hypoglycemia. So you get a benefit, there is no risk, and you have a very low risk of hypoglycemia. The CV and kidney disease safety profiles were consistent across age groups. In 3P MACE, as you can see, there is no difference with the ball standing right in the middle of this thing. However, I'd like to point out one little bit. If you look at people who have aged more than 75 years, though this did not turn out to be statistically significant, the 3P MACE with usage of linagliptin had a trend towards reduction with the usage of linagliptin. In addition, heart failure was not reduced, and neither was any kind of kidney outcomes affected by the usage of linagliptin. Also, if you look at the elderly and the infirm, in patients with less than 65, more than 65, 75, less than 80, and more than 80, what is most important for this group of people is that these people do not have any side effects. These people tolerate the drug, yet get the benefit of glycemia, yet get the benefit of safety in terms of renal and cardiovascular outcomes. And as you can see, in all these groups, people with adverse events were minimal. These kind of events were comparable to placebo, which would indicate that this has no side effect regardless of age. In addition to that, we look at the Carolina data, we look at the safety and profiles, and you can see very clearly that there is no difference in 3P MACE, heart failure, or CV death. However, as you would expect, sulfonylurea is a potent hypoglycemic agent which causes quite a bit of symptomatic and severe hypoglycemia. And linagliptin, when you compare it, whether you look at the younger people or the older people or the very elderly, there was a statistically very high significant reduction of linagliptin versus sulfonylurea. Not only that, if you look at the key secondary sustainability endpoint, the proportion of patients who achieved an HbA1c target of 7% without having any further treatment or without hypoglycemia or without weight gain was statistically, and as you can see clinically, quite significantly higher with linagliptin regardless of age all across the board. So I've shown you multiple benefits. But what are the practical beneficial aspects of linagliptin in simplifying type 2 diabetes? First of all, it's a one pill, one per day, and it doesn't need a lot of monitoring because you can prescribe it irrespective of kidney function, ethnicity, hepatic function, disease duration, BMI, background, or age. Also, because it can be administered once daily, we know it has high affinity with high selectivity, tight binding, high potency, and long duration of action. In addition, if you look at the usage of linagliptin in patients with kidney disease, and I think this makes a very strong mark out for linagliptin, in a country where follow-up of patients is very poor, patients might see you one day and continue to take a drug that you prescribe for the next 10 years without having any tests or without having even their serum creatinine monitored. This drug is extremely beneficial because it comes in a one dose and you do not need to worry about the kidney excretion rates, which is why it is the first DPP-4 inhibitor and the only DPP-4 inhibitor that does not require any dose reduction based on kidney function. The dose remains the same. So to summarize, therefore, the efficacy of linagliptin is proven across the board of diabetes and has been demonstrated not only in patients who have an HbA1c near the target, but also with high HbA1c. It is shown to be safe in CV and kidney disease. Probably some degree of benefit might be there in certain subgroups, but definitely if you compare it with sulfonylurea, it causes too because it reduces the risk of hypoglycemia, and it can be prescribed to a wide variety of patients as once daily, one dose, once daily, for a broad range of patients regardless of their diabetic control. Thank you very much for listening.
It was indeed wonderful talk, sir. We consider DPP-4 as a molecule for lockdown, and one of the safest among DPP-4 is linagliptin. So, thank you, sir. In the future time, we are not doing question answer right now. Moving to the next talk, and I would like my co-chair to introduce the next speaker.
Though sir needs no introduction, it is my honor to introduce Dr. A.G. Unnikrishnan sir. He is the CEO and Chief Endocrinologist of Chalaram Diabetes Institute in Pune. He has more than 190 PubMed Index publications and has co-authored the largest worldwide multicentric study on pancreatic diabetes. He has also received multiple prestigious awards, including the Subhash Mukherjee Oration Award by the Endocrine Society of India and the Sri Vastava Award by RSSBI in 2011. Over to you, sir.
Thank you. It's a pleasure being here, and I thank the organizers for inviting me, and the chairpersons for the kind introduction. May I have my slides shown? I can see my slides here, but thank you. So may I begin my presentation? So I'm going to talk about timely intervention in type 2 diabetes with a focus on the SGLT2 DPP-4 inhibitor combinations which are now going to be available. So uncontrolled diabetes is a major concern globally, and that requires no introduction to a novelist audience like this. And if you look at our patients, a large majority of them have an A1C which is high. early intervention, if you intervene very early, you increase the chance of better and sustained control. So this is data. In the x-axis you'll see the time, and the y-axis you see the probability of having A1C under control. And you'll see that people whose A1C, initial A1C was above 7 versus above 7.5 versus above 8, people with early intervention did much better. So this is the UKPD study which showed that even a modest reduction in hyperglycemia improves complications. Let's look at a case now. This is a 47-year-old male smoker, type 2 diabetes for 2 years. It is a case for discussion, and is also hypertensive and is fearful of hypoglycemia. He is on metformin 1000 milligrams twice a day, amlodipine, telmisartan, rosuvastatin. On metformin 1000 milligrams twice a day, his HbA1c is 8.6%. As you can see, he is obese. His total cholesterol is 176. The LDL can be a little better. As you can see, the LDL is 107 and his eGFR is 85. So the concerns for this patient is, number one, that he needs to stop smoking. Second is he needs to control his weight. Third is he needs to control his blood sugar, which is very high. But he already has a fear of hypoglycemia, which doesn't mean that sulfonylureas can't be used. Sulfonylureas are excellent drugs to use in management of diabetes. But today when you have other options which do not cause hypoglycemia, like SGLT2 DPP4, it's a combination worth using. Why? Because an early and aggressive control gives a good legacy for the future. The legacy effect, legacy is what we bequeath to the future, and in a legacy effect, good control will have benefits in the long run. So all these options are possible: sulfonylurea, DPP4, SGLT2, basal insulin, GLP-1. So all are possible. What you choose is based on individualization. But instead of going for stepwise therapy, it is better to go for an early combination, bring it down quickly and keep the blood sugar down without hypoglycemia so that you can get benefit. So we know that the natural history of diabetes is that we keep on adding drugs. On one drug the sugar goes up, we add a second drug, a third drug, and then it's insulin. What can be done to reduce this progression? Studies have shown that you can go for an aggressive low-carb diet and you can prevent the complications, the glycemia from worsening. But if you are looking at therapy, it's always good to add a therapy which can control the blood glucose levels without hypoglycemia. The combination of SGLT2 and DPP4 has many advantages. DPP4 inhibitors are cardiovascular neutral, weight neutral, control the blood glucose, and as Dr. Sinha showed, they are excellent drugs at controlling blood glucose levels. On the other hand, SGLT2 inhibitors reduce the body weight, reduce the cardiac risk, reduce the renal risk, control the blood sugar, control the BP. So the combination of these drugs could have an incremental benefit. And this is an example of one such combination. There are several such combinations available. You have a dapagliflozin-based combination, you have canagliflozin-based combination. Of course, canagliflozin-based combination not available, but you have empagliflozin-based combination, you have renogliflozin-based combination. This is just an example of one such combination, which is empagliflozin. The advantage of this particular combination, both have got cardiovascular outcome trials with proven efficacy, and you will see that in both these groups, the A1C control is very good, and you can see the A1C control is maintained. So one of the advantages of using a combination like could be empagliflozin, linagliptin, could be dapagliflozin and another gliptin, whatever the combination, you bring it down quickly and you can keep it down for a longer period of time. And that's why with these combinations which don't cause hypoglycemia, we are able to reach much better A1C controls without hypoglycemia. And if you see the empagliflozin data here, both the 25/5 and the 10/5 reduce A1C by 1.6 to 1.8%. And if you see the percentage of people who reach control, that's also higher in the combination. And this combination comes with reduction in weight, blood pressure, uric acid reduction. And you can see the hypoglycemia is not a problem with the SGLT2 DPP4 combinations. There is some evidence that DPP4s moderate the risk of genitourinary tract infections. There is some evidence, but this evidence is not really this is just one study and this is just one meta-analysis published earlier. Do I really think this is a valid study? We don't know yet. But at the same time, this is one study that suggested that. But this needs to be looked at in greater depth in future studies, whether this really happens. There are some basic studies looking at the mechanism also. In clinical practice, I'm not sure whether DPP-4s are blunting urogenital infections with SGLT2 inhibitors. But yes, there is a study, and I'm just showing you the study. So if you see the combination of dapagliflozin or empagliflozin and linagliptin or any other gliptin, what these drugs do is that our goal of treatment is not just glucose control. We want it to be brought down and stay down. We don't want hypoglycemia. We want cardiorenal protection. We want weight reduction and blood pressure reduction. And if you see all that, then if you see everything together, I think it is the metformin plus SGLT2 plus DPP4 which gives you all the benefits. And today, cost is also not a concern because you have economical such agents also available. So I think it is good for diabetes because this is available for our patients. At the same time, if you look at empagliflozin and linagliptin, this is a combination where both the components are supported by cardiovascular outcome trials in clinical practice. So if you see the doses once a day, that's an advantage. And non-adherence to treatment has many reasons. One reason is hypoglycemia. Another reason is weight gain. Sometimes cost is a factor for non-adherence. So whenever we look at non-adherence, we should look at it from a long-term perspective and find out how that non-adherence can be corrected. In today's world, when you have a combination pill, that could increase adherence. And improving adherence actually, and this is not for any drug, it could be for any drug or lifestyle, if you improve patients' adherence to diet, physical activity, medication, you can actually reduce the need for acute care. The study showed in type 2 diabetes, higher adherence to glucose-lowering agents was associated with less need for acute care, less hospitalizations and reduced complications. So there is very clear evidence that adherence is important, and you can see the cardiovascular benefit of SGLT2 inhibitors and the cardiovascular neutrality of linagliptin, which was shown, and also the reduction in albuminuria which was seen in the Camarena study. There is some real-world evidence supporting the benefits of this combination, and I come back to the gentleman. And if this gentleman were to be given a combination of SGLT2 and lina or DPP inhibitor, and here I don't restrict myself to empagliflozin and linagliptin, but it could be any such combination. I think that combination will improve compliance, reduce weight, reduce cardiovascular renal risk. And this is a patient who's, as you can see, the eGFR is 53. So the eGFR for using SGLT2 inhibitor, the KDIGO guidelines put a cutoff of about 30. For empagliflozin, I'm told it is 45. For all other SGLT2 inhibitors, it is 30 on-label use. And you can see that this patient is elderly, is on basal bolus insulin. Of course, I've written the brand names. And you can see the time and range is pretty good. A little bit of hypoglycemia because of insulin, but you will see the good control. So I like to say that we need to move from a cardiovascular to a cardiovascular renal complication prevention perspective from a purely A1C perspective. And we also need to think beyond the task of controlling the blood sugar, controlling the blood pressure, managing the weight is not the onus of the patient alone. But I think with these drugs, we are able to help the patients reach better targets without hypoglycemia, with some weight loss, with cardiorenal protection. And I think it's also a time to make sure that diet and exercise is maximized, so medication load is minimized, and combinations are used to improve adherence and also keep the cost into consideration. Pleasure talking to all of you. Thank you for sharing the session. It's wonderful being here.
Thank you, sir, for the wonderful talk.